Uh, yeah, good evening, everyone. So today we'll be doing like a mixed mark session. As people are joining, I'll just quickly talk about our course that we have planned for Diet 1 2026, covering January, February exams. So it will mainly be like mock style practice session, something like what we're doing today. It will be station wise, system wise, and mixed mocks, everything. So that there will be a clear cut approach to various scenarios, how each scenario is expected to be dealt with in actual exam, how you can tackle each of the difficulties that you face in those exams, like that. Uh, so this will be highly interactive sessions, as in you guys can talk, have whatever doubts you have, we'll be able to clarify that. Similarly, whatever tips or how differently you can approach, what basic format you can use so that you can easily approach the station. All those will be clearly told. We are planning to do 3 sessions per week. And it is quite very cost effective based on how much knowledge you gain, and we also know how costly this exam is. So when you weigh all that together, this is actually very cost effective course. And recordings will be available
Be
till we
nice.
are giving exams. Recordings will be available
Kira po
throughout.
small thing alam yo. Yeah.
Yeah, so we are what we are doing is we are dividing the course into large group and small group. Two types of groups, so that two types of groups, so that small group will have more frequent practice compared to the large group. Though that's why there are three different sessions, 3 sessions for large group per week and 3 sessions for small group per week. But then the content of the sessions will all be the same. It's not like we are going to give a better content for a small group, and there's nothing like that. It is the same content that will be taught for both the large group and the small group. Just that when you are in a small group, the number of practice sessions that you get is better. That's the only difference. And so these are a few testimonials that we received just for this previous diet, uh, and the current diet, half of it, for which results have recently come. All of them have taken our main course, intensive revision, rapid revision courses, or practice sessions, or mock exams, both the online mock and the in-person mock. And this is all feedback based on their experience with us over the last few months, or for the previous diet. The main thing about the UK exam is that it's quite different from our usual postgraduate exams, except for those countries where UK exam is kind of like the only post graduation degree. Those countries where UK degrees, I mean, MRCPCH is an add-on to your already existing degree. For us, we already have some basic knowledge. The base is already there. You just need practice, or get to know what is different in MRCPCH. So I mean, how is it different from your previous post graduation course? And just small tweaks accordingly. Only that is going to be a difference. Those who already have a basic knowledge and basic foundation. For those for whom MRCPCH is like the only post graduation degree, like some of them after their undergraduation from their respective countries, they directly do MRCPCH as a post graduation. While in some countries, MRCPCH is the only available post graduation. So in those countries also, our course is going to be helpful, because we are going to tailor our classes accordingly, based on the content of the group, people who are available or who have joined our course. Based on that, the content is obviously going to be there. We do have our website. The website is targetmrcpch.com. So from there, you can download our app. We have like 6 courses currently in the app. MRCPCH Clinical, that is like the long course. It has right from the beginners part. It has everything. Uh, like basics, what format to use for each station, example that seem to have worked so far, like that. Intensive revision will be like when you've already started preparing, but then you just need proper revision and proper guidance for each scenarios. Maybe 2 to 3 months only you have left until your exams. Then intensive revision will help. Clinical crash course is when you only have like 1 month or 1.5 months left for your exam. You need proper rapid revision. You have already prepared as much as possible. You've already practiced as much as possible. Just that fine tuning is left out. Then clinical crash course will help. We also have the free course wherein we've uploaded all our free content, like whatever previously we have taken. And these are all upcoming. I mean, this is the current group, and this is the upcoming session. So if enough people have joined, we can probably move on. The first one will be communication. I think Dr. Saranan had volunteered for doing communication. Yes.
Yes, ma'am.
Uh, I guess all of you are familiar with the format for each station, as in there will be 4 minutes wherein you'll be sitting outside the station. You'll have a chair and a scenario wherein those 4 minutes will be for reading the scenario and gathering your thoughts. And then once that 4 minutes is over, you leave the scenario outside and then go inside. And for communication, it will be 9 minutes to deal with the scenario, in which after 6 minutes is over, they'll give you a knock for the final 3 minutes. And once the 9 minutes is done, you will move out of the room. So now we'll be doing those 4 minutes now to read the scenario. If any glitches in the screen, please do alert me. So this is the scenario. Time starts now.
Ma'am, I am ready.
Yeah, sure.
Should we
So
start?
9 minutes, the time starts.
Okay. So, good morning. I'm Saravanan. I'm a child doctor here. I have been managing Harvard. You know me. Am I talking to Laila, mother of Howard?
Hello, doctor. Yes, doctor.
Hi, Laila. How are you doing, and how is Harvard doing?
Yeah, you know, doctor, like we have quite a lot of history, and we have been with you guys for so long. The thing is, recently, despite how good Howard is with how he deals with his disease, but despite all that, recently he started losing weight. We don't know what is happening, so we, I mean, we've come back for an update.
Yes, Laila, I understand that Howard has not been keeping well recently. So, first of all, I would like to tell that we have been very happy with Howard's complaints to treatment. You both have been doing really well despite the disease has been, the condition is very difficult to manage, right? You must be finding it difficult.
Yeah, yeah, it has been a very big journey, doctor.
Yeah, so we completely understand, but we have been following you up, and we are always happy with the way Howard copes up with the treatment. Miss Laila, so should we discuss about the current issues about Howard?
Yes, yes, please, doctor. I wish to know what is exactly happening.
Yeah. So before I start, do you want anyone to join, Howard's father or anyone to join with us?
No, doctor, it's just me and Howard today.
Okay, and I hope you're okay with Howard being around, and I hope Howard also is mature enough to understand things, right?
Yes, yes, doctor.
Okay.
They have even been talking about transitioning him to, adult clinic. They said that it's a long process, so I guess Howard should be there.
Yeah, yeah, that's true. That's true. Thank you for your understanding. So, Miss Laila, we did some tests to find out why Howard was losing weight. Yes, and
Yes, yes, doctor.
we have got some test results, and I want to discuss that with you. Okay.
Okay. Hope it's nothing bad, doctor.
So, I'm sorry to say that I don't have really good news for you today, Laila, but still, I'll explain things step by step so that you understand and follow me. Is it okay, Laila? Shall I proceed?
Okay, yeah, sure, doctor.
Yeah. So, Laila, as you know, we would have explained multiple times that cystic fibrosis is a condition which will involve many parts of the body, right?
Yeah, yeah, doctor.
Yeah, so you have been coping up with the lung problem well, and you have been giving medicines that helps in his digestion, right?
Yes, yes,
Yeah.
doctor.
So despite all the medicines, the current weight loss, the report has come as cystic fibrosis related diabetes. Have you heard of this term, Miss Laila?
No, doctor, it's quite new to me. What is it, doctor?
Okay, so I hope you understand the word diabetes. Have you heard of it anytime? May I
Oh,
know?
yeah, doctor. Yeah,
Okay, so may I know what you know about diabetes?
Uh, like my uncle has diabetes, doctor. For him, sugar levels are quite high. So they gave him tablets to bring the sugar level. Is that what is happening for Harvard, doctor? Like his sugar is high.
Yes, Miss Laila. So the weight loss is due to some alteration in his sugar levels. Okay, so let me explain this to you. I understand that you will feel anxious regarding the diagnosis. Let me explain this to you. Please allow me. Okay.
Okay, sure, doctor.
So, as you know, in cystic fibrosis, the secretions become thick and it damages the lung. That is what is happening throughout this disease, right? So, so,
Uh,
So the mucus becomes very thick and then it blocks the airways. That is the prime
Yes,
problem with the disease, right? So
yes,
hope you
doctor.
remember that. So similarly, there is a part of the body in the tummy. Okay, it is called the pancreas. Have you heard of this term?
Uh, yeah, when they explained about cystic fibrosis, they also said that it also affects something like what you're telling, doctor. So let's do what you're
Yes,
telling.
correct, correct. So I'm glad you remember that. So this organ
Thank
called
you.
pancreas, it is important.
Mm.
It is an important organ which secretes some juices. Okay, so it helps in digestion. So as we know, we have been giving this crayon capsules. I'm sure you have been giving to him, right?
Yes, yes, doctor. We've been making sure that he takes it regularly.
Yeah,
No
yeah. So
excuses.
yeah, so that is again this pancreatic juice given in that capsule form so that his body digests the food that he eats. Okay, so apart from this, this pancreas also secretes another chemical which helps in controlling his sugar, that is called insulin. Have you heard
Oh,
insulin? Like,
I know that heard about it, doctor, but I'm not sure about it.
okay, so let me explain. So the pancreas
3 minutes
also,
left.
okay, the
Mm.
pancreas also secretes this chemical called insulin. Okay, so
Okay.
this insulin helps in controlling our blood sugar all the time. Okay,
Okay.
so right now what is happening is because of the disease, the pancreas, the insulin secretion has come down in the pancreas. That is causing this
Okay.
problem for Howard.
Okay. Okay. So what should we doctor do, doctor? What is the cure?
Laila, the thing is, it is going to be another set of treatment which includes checking sugars for Howard again and repeatedly, and then we have to treat him with insulin injections. That is going to be the treatment for this condition.
Oh, I hope just one injection, doctor. We are already fighting a lifelong battle. We don't want anything else going on.
Yeah, that is completely understandable. Your worry is completely understandable, Laila. So I'm sorry that this condition, this insulin has to be given to control the sugar throughout the day. So it will be multiple injections and multiple times sugar.
Oh, no way, doctor. What are you telling? I cannot put my child through something else again, all through, no, doctor.
Miss Laila, I'm completely understanding that it must be very difficult for you to take in. So, so yeah, I assure you that you are not alone in this. We are going to take you through this step by step. Okay, so please take your time and try to understand that Howard needs this now. Laila, are you with me?
Yeah, doctor, this is like, I don't know, too much for me to handle actually.
I completely understand. So, what we can do is, so we are going to arrange a meeting with a dietitian and the hormone doctor involved, the chemical, gland doctor, in another setting with you, so that we can explain you how to take you through this. Is it okay, Miss Laila?
But my uncle only takes tablets, doctor. We can at least give him tablets, not at least avoid injections. He's already taking tons of tablets. Maybe he can take one or
Yes.
two more.
Yes, that's very valid to think like that. So these are different conditions, Miss Laila. That the one that adults develop is different. That their insulin is not working. Here, this chemical is not being produced. That is the problem. The problems are different here. Are you with me?
Uh, yes, doctor.
Miss Laila, I want to give more time for you to take this information. I don't want you to overburden yourself. So I'll be glad to arrange a meeting, as I said, with the concerned team involved so that you will be taken through this step by step so that it will be more clearer to you. Um,
Okay, sure, doctor. Yeah.
so Miss Laila, we will be we will be with you through this journey step by step, okay? And we will make sure that you cope up with this treatment also, just like you have always did, okay?
Yeah, doctor.
So,
Okay, yeah, your time is up.
okay,
Yeah.
yes, ma'am. Mm,
Yeah, Dr. Saruna, it was a very good attempt. I mean,
uh,
quite a difficult scenario because, yeah, you wanted to say something.
Uh, no, I'm like I understood that I missed the speed initially. Like I took little more time,
Yeah.
so that's why I
And then
could
to
not.
recover from that, it took quite a lot of time for you. I mean, you couldn't recover from that. Time.
Yeah, yeah. So
Yeah.
that was the mistake. I understood around 4 5 minutes. I understood that
Yeah.
okay, okay. I became late. Then I
Yeah.
could not rush it also. So
Yeah.
yeah, so I diverted it to dietitian and gland doctor so that I can
Yeah.
finish it sooner. But I could have done better if I have cut down the initial part little bit more. That is what I felt.
No, anyways, whatever you did had to be done. Maybe that you could have done it quicker. That's all. Otherwise, it was a very good attempt. I mean, you were able to cover everything that was required for the scenario today.
Okay,
Maybe the mother had a couple of concerns if you what we call as pass the mic. If you talk in short sentences and give more pauses, maybe we'll be able to unravel even more concerns
okay, ma'am.
because that's how it will usually be in exam also. They'll have two, three concerns for uh, given to the role player that
Okay, ma'am.
we do it. Once you
Mm,
clear all the concerns, it's on
yes,
full
ma'am.
marks. Model is on full marks, so you can be very confident.
Ma'am, I didn't hear you.
You'll get full marks once you clear all the concerns. You can be confident about it.
Okay, ma'am. Okay, ma'am. Sure.
Uh, So how you could have gone is, hello Laila, it's nice meeting you again. How is Howard doing? Maybe something like that you can ask, and she'll tell, yeah, doctor, we are here, and then now he's losing weight, and they've done a lot of tests. So we've come back for an update. Yes, I know how long things have been, going like this for you. Now I've come to talk with you only about the results of the tests that were done previously when you visited. Okay, doctor, or is it something bad like that? She'll ask. Yeah, let me talk in detail with you about it. Would you like anyone else to be there? And she'll
yeah,
tell, no. Then you can directly tell, so you're already aware of what cystic fibrosis is. It mainly affects lungs and pancreas. I guess, two organs that are there in the body. I guess all this have been explained to you already and you're clear with it. She'll say yes. So that much is okay.
yeah.
Because when you said lung, it will have mucus, and then that will cause, that is already pathophysiology of cystic fibrosis. But then we don't have time for that. No, we have to talk about pathophysiology of CFRD, and then
And I also felt that I didn't break the bad news a little early. Like I should
early,
have.
yeah, yeah.
Yeah,
You
that
were
that.
at 2.5 to 3 minutes when you finally said the word.
Yeah, yeah, that was the mistake actually.
Yeah.
So yeah,
So then,
it's because that is because first I asked how he is doing, and then I was appreciating their follow up and complaints, and
yeah,
took two sentences. Then it was
yeah,
2 3 minutes. Yeah. Okay.
yeah. So that's what the 4 minutes I would say will help, for you to plan your scenario, how you want to take it,
Yeah.
what all you want to. Sometimes when it is difficult, no, I'll even write it down in my rough sheet, whatever they give me, so that I can just quickly bend down and see what they have. Talking point, next talking point, like that.
Yes, ma'am.
Um, yeah. So after that is done, then you'll ask if she knows the term cystic fibrosis related diabetes, and she'll be like, no, I don't know. But then I hope you're already aware about diabetes, like you asked, and she'll say her uncle has diabetes tablets, and then you'll tell, oh, what you could do, you could have done there is you could have appreciated her knowledge.
Yeah.
You just asked her if she has. So she has. So maybe if you appreciate it, it'll even sound better.
Okay.
All these there's developing rapport along the way,
Okay.
uh, and softening the blow. Because the child is already undergoing a chronic disease, and I'm going to talk about another chronic disease. Obviously, it's going to be too much for the mother.
Yes, ma'am.
So, yeah. And one more thing is they've put that you have to talk with both Laila and Howard.
Yeah, yeah. How to do that, ma'am? I have never done it. So I was
Yeah,
like, felt it in between that I am not
yeah,
talking forward.
yeah.
So
Most of them, they're
whom to focus on that is because it is totally different to talk to the teenager himself and then mother. Already time is less. So how to
yeah.
both of them? What if they start talking and what? That is the question.
Yeah, it's a difficult situation. This was also recently, I think it was asked at the start of the year. Uh, since we are not exactly sure about the
Your
action.
line is not clear.
Oh, okay.
Uh, but is yeah, others
Is
also
it
not.
better now?
No, ma'am, some disturbance is coming.
Disturbance is there. Uh, I'm
It's
not sure
not.
if this is from my side or not.
It's not the sound. It's there's some extra sound going on coming.
Oh, okay. I think someone else is. I muted.
Someone else.
Oh, I muted you instead. I'm sorry. Please unmute yourself.
Okay, ma'am. Yeah.
Okay,
No.
sorry.
Mm. Yes, ma'am.
So yeah, a few things to remember, especially when there are two people. One thing is there might be two role players. One can be Laila, one can be Howard. Or if Howard's participation is going to be quite less, then they'll have only one role player. Say that imagine that both of them are only this one person and then talk, which
Okay.
means his involvement is going to be quite less. That is one thing. Second thing, anyways, you'll have to acknowledge both of them. Like, I hope Howard is also clear with what we are talking, like that. And then one more line that you can tell, if at all Howard has some doubts and he wants it to get clarified. One more line that you can add is, I would like to talk with Howard separately also once, so that I can discuss in detail with him and clarify his doubts better. That also
Yes,
you can tell, because the mother he may not open up fully.
yes, ma'am. Yes,
Because anyways, just appreciate that Howard is there. You know that he's present. You're just acknowledging his presence also. I think that must be more than enough here. Unless Howard has some doubts, then
yes,
you
ma'am.
will have to.
That's why I asked. Like, I didn't know whether it was like okay to ask. Are you okay, Howard, being with us like that? So that was what I.
No, if he says no, I want my mother to go outside. In the
No,
scenario,
no, no. I asked the mother
uh,
whether it's okay Howard to stay because
yeah,
we are
yeah.
doing for the first time. We are explaining for the first time. So so whether we should talk to the parent first and then open the
So,
thing to.
like I said, since the task itself is you have to talk with both of them, this is how you'll have to deal with it. The task says that you have to talk with both of them. So, you cannot deal with each of them separately, at least in this scenario. Whatever
Hmm.
task is given to you,
Yeah.
you have to talk. Yeah.
Okay. Okay.
Doctor,
Okay.
then in this scenario, if the task is talk to both of them, then is it necessary to ask, like, is it okay if Howard is here around us, or we can just
No.
skip that question?
Yeah,
Yeah.
you
Let's
have
skip the
to
question. I think.
talk with both of them. So, I mean, you can skip that.
Yeah. So I could have replaced that question with something else.
Something else. Yeah.
Howard, I can tell that Howard, if you have any doubts, you cannot follow me. You can stop me at any time. Something like that. I
Anytime.
would replace
Yeah,
it.
and also that you'll be happy to
Talk to
have
you
a separate
separately
meeting
as
with
well.
Howard
Yeah.
also and clarify his doubts.
Yeah. So that I could have changed that into that. Yeah. That would have
Yeah.
worked. Yes. Okay.
Then, when we will break the bad news, Howard will be also there. Then he will also react like the mother reacted. Both of them are sitting together. He'll react
Depends on
more
the
easily.
scenario that's written. Depends on the scenario that's written. He can also react.
Yes.
If
And
this
then we
single
have to
scenario
calm
can
both
go.
down.
Yeah.
So we have to tell this. This is overwhelming for the family, for us as well. Everything. Everyone is
If
overwhelmed. Yeah.
Yeah, whenever Howard is reacting, you like just like you're pacifying the mother, you have to pacify Howard also, and then tell that you are happy to have a separate meeting so that Howard's participation is less there. Obviously, he's only 13 years old. It's not like he's going to make the decisions majorly. It's going to be Laila, the mother, who's going to make major decisions. I mean, the decision majorly. So, keeping that into consideration because that's how the format is also. Howard's involvement will also be less.
Yes, ma'am.
That is how they will frame the scenario also. So
Okay.
then, since this is like first time that you're explaining about pathophysiology and all, what could have helped is just drawing a simple pancreas diagram. That's all, and
Yes, ma'am.
then showing to the mother. Maybe because this is online, you felt comfortable
Yes,
talking,
ma'am. Yeah.
in a better way. But
We
then
were
in
planning
actual
to
exam,
in,
just
in
draw a
India.
pancreas, maybe draw a stomach and some bowel next to it, and say that from pancreas insulin goes into the bowel, and that's how sugar is maintained or something like that, or into the blood, and that's how sugar is maintained. All those you can tell. Basically, whenever we are doing information giving, try to draw a diagram, so that it sits better with the role player and sits better with the examiner.
Okay.
And then you will also have to tell that, just like you said, the dietitian has to be involved, the gland doctor has to be involved. Uh, they will have to maintain proper follow-up. That all will come.
Yes, ma'am.
I just have a few talking points here. Uh, some materials here that can help you guys with it. How do you diagnose using OGTT or
Yeah.
CGM is continuous glucose monitoring? But then the main thing is OGTT.
Yeah. So here it was diagnosed, so that's why like we
Yeah,
were not working up, but yeah, what
yeah.
it did.
I mean, because we just have one format, and based on that, we are trying to branch out
Yes.
into other formats that can be so for that, I've just put reading materials.
Okay, ma'am.
Then other things that you can tell is annual review will be very important. Just like you come for cystic fibrosis, we'll also make you, see the specialist for CFRD, cystic fibrosis related diabetes also, so that all those any side complications or anything else is expected, those can be tackled with. Any blood tests have to be done. They can be done along with the cystic fibrosis blood tests. These can also be done. We can combine so that.
Okay, ma'am.
Yeah, and then what are the complications? You can tell the complications are similar to what your uncle would have been told, so that it can be made more familiar for her. Though we'll talk about this in detail in our upcoming meetings, like that you can tell.
Yes, ma'am. And in this particular scenario, it is better not to go till complications. No, if it is this scenario, like when we are first.
You just put a line. You have to be on follow up so that clean for all those. Make sure that everything is going well. And then in subsequent meetings, we'll be talking about all that in detail. Meanwhile, she'll ask what is there a cure and all that. So then you'll tell it is insulin is the mainstay of treatment. So then whatever we had, then mother will tell he's taking tablets. Why can't he take tablets? No injections and all that. So that's how it will go usually. So 2, 3 concerns that the mother has, we just have to clarify all that. After that, once you feel that the scenario is coming to an end, you can probably ask if she has any other concerns. Once the mother agrees, Laila, Howard, or you can, if because you'll have to talk with both of them. Do any of you have any concerns? Once they both agree that they don't have any concerns, or they say that I'm still processing or something like that, then you can say that yes, it must be very shocking to you, or I cannot even understand what you might be going through, something like that. Some empathetic line you can add, and then you can say that I'll give you further reading materials and website links and all, where from you can gain more knowledge about the actual disease, and then come back for the meeting with my own consultant and with the gland doctor. So whatever further doubts you have, you can get it clarified from them. If she is okay, then you can quickly summarize and wind up. So that's how it is.
Okay, ma'am.
2, 3 things that mainly you guys will have to remember is that one thing is keep your sentences short so that I mean, if you talk for 2 minutes, obviously we are not going to comprehend what you're talking about. It is all complex. So try to cut down your sentences and into shorter ones, and also give pauses wherever possible. Check the understanding so that if at all they have any doubts, they'll ask in between. Um, Whatever concerns they have, I mean, it's like you're giving some gap for their concerns to come out, and you can tackle them. And I mean, wind up the scenario, finish the scenario.
And
Hope
So
everyone
usually, how many questions does the role player have?
there is no hard and fast rule. It completely depends on each of
No,
the
like
scenarios.
for example, how many we can expect that he will be having? So like we'll be able to understand about the time
Yeah, like I
management.
said, no hard and fast rule at all. They can have 10 questions. They won't let you talk at all. They'll have only two, three concerns. It completely depends on each scenario. It varies completely with each scenario.
Okay, doctor.
and in this we can give a leaflet to know.
Yeah,
Yeah, this is a new diagnosis, so it will be helpful for them if we give
yeah.
references.
Reading materials and website links.
Okay, ma'am. Thank you.
Thank you, Dr. Karan. It was a very nicely done scenario. So if everyone is okay, we can probably move on to the next one. I think I have a video and I saw Dr. Shajita had posted if she wants to volunteer for video station.
Yeah, yeah, ma'am. Am I audible, ma'am?
Yes, yes, Dr. Shajita.
Yeah,
Uh, so you should a video station. The 4 minutes outside will have something like this, just a seminar on what you can expect when you go inside, and then once you go inside, you have minutes for video also. In which 3 minutes you'll watch the video how many times ever you want, and then the next 6 minutes will be for discussion. So the stem that you have outside is a video 6 years old boy who is presented with abdomen pain and diarrhea, and the video does not have any sound. If you're ready, I'll share the video.
yeah, ma'am. Yeah, ma'am.
So we'll have 3 minutes to watch the video. Once 3 minutes is done, we'll directly start the questions.
Okay.
I hope the video is visible. Your time
Yeah,
starts.
Okay.
We have another 30 seconds. Maybe we'll just finish this video as it's running and then we'll start.
Okay.
Okay, yeah. Please describe the findings that you saw in the video today.
Yeah, I had the opportunity to see a 5-year-old boy, probably examined in the clinical setting, and his dimensions, height, weight appears to be normal for his age, and I do not find any distress. He does not have any dysmorphism, and there is no devices in the surroundings as well. The child on walking is having a antalgic type of gait, and he's being examined on the couch. There is visible purpura in the lower limbs. And there is a last test done, which shows that the rash is non-blanchable. And yeah, so that's me.
Yeah, so
Considering
based on your findings, what are your differential diagnosis?
with the background history of abdominal pain, diarrhea, and with the antalgic gait and palpable rash, I would keep HSP as my first differential. And since the child is not toxic, meningococcemia is down the lane, I would consider any other vasculitis cause here, like IgA vasculitis. Or any other autoimmune vasculitis in this, but age does not seem to be appropriate. And ITP is also down the lane since it is a the differentials of HSP, ITP, and meningococcemia and other vasculitis.
Okay, what history would you like to ask from the parents?
I would like to ask about the onset of this rash and the onset of this the entire abdominal pain, diarrhea, and this antalgic gait as well. I would ask about any associated fever, and I would ask about the distribution of the rash, where it started and how it has progressed now, whether there is associated pain, itching with the rash, and any burning also. And I would ask if the rash is blanchable or not, and then I would ask about severity of the abdominal pain, how severe it is, if there is any blood or mucus associated with the loose stools that he has, and how his urine output is at present. If there is any reduced urine output, I would like to ask, and then I would like to ask about other general well-being of the child as well, if his intake and is adequate. And I would like to ask about other red flags about his sensorium and overall output and urine output. And for the past history, I would ask if this is a first episode or it has a recurrent episode that he has, and any other chronic illness he has, and if he's on any medications for any other chronic illness. And I would like to ask about any about his vaccination history, and about any family history of similar illnesses or any other autoimmune illnesses in the family.
Okay, and what would you want to look for in examination?
I would like to plot his dimensions and confirm that he's doing well for his age. And I would like to do a head-to-toe complete examination about the distribution of the rash. And I would like to do a GC's assessment and abdominal examination. If there is any tenderness or any mass in the abdomen. And yeah, I would like to do a bedside vitals as well. I would like to do capillary refill time, BP, and heart rate and saturation and respiratory rate.
Okay, any bedside test you would like to do?
Yeah, I would like to check for the rash if it is blanchable or not by doing the glass test, which is and demonstrated in the video. I would like to do the blood pressure measurement and blood glucose measurement.
Uh, okay. What other investigations would you like to do?
I would like to do a complete blood count and to rule out thrombocytopenia for the rash. I would like to do inflammatory markers like ESR, CRP to rule out ongoing inflammation. I would like to do renal function test, urea, creatinine, and electrolytes as well. I would like to do USG abdomen to rule out the complication of HSP if he has any intersusception. And if at all any imaging is required for his antalgic gait, I would like to do an X-ray. Yeah. Yes, ma'am. I would like to do blood culture as well. And I would like to do urine examination, urine dipstick, and to look for hematuria or proteinuria.
Okay. What will be your immediate management?
Sorry, ma'am, you're not audible.
What will be your immediate management? How do you want to manage?
I would like to I would like to admit the child, and I would like to involve multidisciplinary team involving a pediatrician, and if at all, I would like to treat his pain initially with NSAIDs. Probably naproxen. I would like to start for HSP, and if at all, if there is severe abdominal pain and intersusception is suspected or severe arthralgia, I would like to start him on steroids for the same.
What will be the indication for admission?
Indications would be more than 2 joint involvement and severe abdominal pain and suspicion of intersusception. If there is associated AKI, Sure.
Okay. So how do you want to monitor and follow up this child?
We would like to follow the child with regular BP management, and if at all the child had renal involvement, we would like to follow him up with the urine dipstick until his proteinuria settles. And yes, with BP and urine dipstick, I would like to follow up the child. If at all the child has renal involvement, I would like to refer the child to a pediatric nephrologist as well. And yeah, we would do a nephro follow-up for the child.
Okay, yeah. Your time is over.
Okay.
So yes, this is Henoth-Conlin purpura because there are rashes which are when you see the glass test, the rashes are non-blanchable. And the child seems to have arthritis. Whereas the child, in the initial part of the video, the child has difficulty bearing weight in one leg,
Yes,
and then also antalgic gait, like you described.
Okay.
And we can also see obvious pitting pedal edema towards the end of the video.
Okay. Okay.
All goes along with abdominal area, like you said, it can be Henoth-Conlin purpura. So then, when you put up a differential diagnosis, you can say whether the child is, since the child is well looking, my differentials will be immune thrombocytopenic purpura or any other vasculitic disorders. And if the child is deteriorated, I'll also keep meningococcemia as my another diagnosis, differential diagnosis.
Okay.
And then otherwise, anyways, history, inflammation, everything will be based on the systems that are involved. Like you said, so we'll have to ask history about the rashes and then ask history relevant to GI tract, joint pain, and renal involvement, all those. And this can be hypertension. You can also ask other symptoms like headache, seizures, vomiting, for press. Because those will come as red flag signs that are very important that you cannot miss.
Okay.
In examination, you'll do examination of, general examination wherein you check ABC vitals, including blood pressure, and then all the relevant systems. You'll check for you'll examine abdomen, you'll examine MSK,
Okay. Okay.
and abdomen itself also. And if there are any neurological symptoms, then you'll also do CNS examination.
Okay.
Bedside test will be urine test.
Ma'am, you're not
If
audible, ma'am. Sorry.
yeah, can you hear now?
Yeah, ma'am.
Bedside test will be urine dipstick.
Okay, ma'am. Okay.
Okay. If there is proteinuria on urine dipstick, then the next day we'll send early morning protein creatinine ratio in urine. If there is hematuria, then we'll send urine for microscopy.
Okay, ma'am.
Okay, so if they ask for bedside test, one is urine dipstick, another will be blood pressure, and then also glass test, like you said, to check for blanchability of the rash.
Okay, ma'am.
Okay. Then the investigations
Okay.
that you would like to do will be complete blood count. These are all supportive investigations. Complete blood count, urea creatinine, electrolytes, albumin. Then for
Okay.
your differential diagnosis also, you do other tests like for meningococcemia, you want to do blood culture, ASO titer,
Yes. Okay.
you also do a coagulation profile.
Okay, ma'am.
Then, indication for admission will be either moderate or severe abdomen pain, or if there is orchitis, arthritis involving more than two joints, and there is proteinuria, or any obviously bleeding, gastrointestinal bleeding, or if the child has two joint pain, if the child is not able to ambulate. All those will be indications. Otherwise, immediate management will be, give NSAIDs. Ibuprofen is the first line. Depends on
Okay.
whether the child has renal involvement or whether the child is asthmatic or not. For abdomen pain, we will give prednisolone,
Okay, ma'am.
and it has to be given for 3 weeks.
Okay.
If the abdomen pain is severe, you should also think of other complications. Other questions that they can ask is what are the complications that you will expect in HSP? So pancreatitis, intussusception, bowel perforation, all these complications.
Okay, ma'am. The voice is breaking, ma'am, in between. Sorry.
Okay. So
Ma'am, you were audible
most
only up to the complications, ma'am. Pancreatitis.
after that I didn't talk also.
Okay. Okay.
Okay, yeah. So complications that you'll have to consider is pancreatitis. I think that's what I said. No, pancreatitis, bowel
Mm.
perforation, testicular toxin, all those you'll have to consider.
Okay.
So pediatrician is majorly, it majorly you'll get help from guidelines. There are recent guidelines that were released also, both the pediatric guidelines and neonatal guidelines. And HSP is typically from guidelines only. So I've just posted a screenshot of HSP guidelines. I don't think there is an update in the previous guidelines. Latest update in guidelines doesn't have it for HSP.
Okay.
Ma'am, your voice is not clear so much.
Is it better now?
Yeah, ma'am. It breaks in between. Yes.
There might be some associated sound like from the background or any
Okay.
wind sound.
Okay. Dr. Shishita, can you mute yourself? Maybe unmute whenever required. Can we try that? Now is my voice better?
Yes, ma'am.
Yeah, okay, because I could also hear that extra sound from Dr. Shajita's mic. Okay. So yeah, HSP. Compared to the previous guidelines, there isn't much update for HSP in the new guidelines. And in the new guidelines also, they have highlighted the whatever update in blue, so that it's easier to differentiate. So whatever we've discussed is all there in the guidelines. What history you'll ask, what examination you do, the bedside test is BP and urine dipstick, investigations that you want to do, indications for admission, how do you want to monitor, when will you refer to a nephrologist, when will you refer to a rheumatologist, how do you want to follow up the patient,
Okay. Okay, ma'am. Yeah.
everything. Yeah.
Okay. Yeah, okay, ma'am.
So most of the times, video station, if you read the guidelines thoroughly, it will help. Video stations are usually only acute conditions or those conditions that cannot be kept in exams most of the time. Only sometimes they keep scenarios like HSP, but then HSP again was a recent recall. It was recently asked in exam. That's why I put this in
Okay.
today. Also, they were recently asked reactive arthritis also. Again, that will also be antalgic gait, but then not as sick as this. In rashes may not won't be there. But
Okay.
then antalgic gait for DD. In that reactive arthritis, HSP, everything will be included anyways.
Okay, ma'am. Okay.
Ma'am, and this in this antalgic gait, like Dr. Sabri showed the same video for antalgic gait also. I had a
Yeah.
doubt. The stand space is more in the right lower limb, and it also looks like the right lower limb is involved. I don't know why it is happening. Like if you see the video again, the left foot baby child is keeping on the floor for a longer time. Uh, so
So
let's see.
here, weight bearing is difficult on the right side,
So where is the
and
problem?
then no, it seems shorter to me only on the right side. You can see that he's quickly taking the left and placing it to the front so that he doesn't have to weight bear much on the right side.
Okay.
If we quickly observe,
Okay. So it's the right
that's what is
limb,
happening.
right?
The left, yeah. So it's the right knee that is involved.
Okay. Okay.
And also there was swelling of the ankle joint as well. There was edema, right?
There was pitting pedal edema, saying that there is renal involvement.
Yes, yes, yes.
Okay. Any other doubts, or shall we move on to the next one?
ब्रश की हो ब्रश की हो पापा को
Okay. So next will be clinical station. I think Dr. Sarika had volunteered to do.
Yes,
Is she
doctor.
available?
Yes, doctor.
So yeah, 4 minutes outside clinical station, we usually won't get any information at all. It's just sitting and relaxing and trying to forget whatever happened the previous stations. That's all. And once you enter inside, the examiner will introduce themselves and then get the mark sheet from you and then give the command. The moment you open the door and enter inside, the 9 minutes will start. That is how it usually works. And
Okay, doctor.
once 6 minutes is over, you'll be given a warning saying that there is only 3 minutes left. So the entire 9 minutes will be over when they say 3 minutes left. When they say 3 minutes is left, it doesn't mean that 3 minutes is left for examination. It means that there is only 3 minutes for the even for discussion, examination, whatever. So once they say there is only 3 minutes is left, you should try to wrap up your clinical examination as early as possible. Hopefully, you should have done that even before they give a warning. But then, if you're still examining, try to wind up as early as possible. Uh, so the command that's given for you today is your time starts now. Examine the lower limbs of this 8 years old boy Tom for his motor system.
Okay, so I give my mark sheet to the examiner and I greet Tom's mother. Hello, I'm Dr. Sarika, one of the children's doctor working here. Is it fine if I examine Tom today?
Hello, doctor. Sure, doctor.
Okay, thank you. So, Tom, hello, how are you doing?
Yeah, I'm good, doctor. Thank you.
Okay, so I see how is Tom? Is he well? Is he alert? Is he communicating with me?
Yeah, doctor. He is talking well with you.
Okay, is he syndromic? Do I see anything syndromic?
No obvious dysmorphism that you can see.
Okay, is he wearing any eyeglasses or any hearing aids?
No.
Anything in the surrounding?
No.
Okay, fine. So now I tell Tom, can you please come here and stand? So I have a look at him from the top to the bottom. So I see his head. Is there any microcephaly, anything?
No, no obvious head size difference.
Okay. Anything in the eyes? Any nystagmus? Mm,
No.
okay. I see his nose and I quickly see his mouth. So do I see anything?
No, his oral hygiene is normal.
Okay. I see his ears and behind the ears. Is there any shunt or anything or any hearing aid?
No.
Or any hyoscine patch or anything? Okay, fine. So now I see his neck. Do I see any scars, any sinuses or anything in the neck?
No.
Okay, I see him from the front, the chest, any chest deformity, obvious, anything in the abdomen, any stomas or any potacath or anything?
No, no.
Okay, I see his legs. Is there any atrophy, any asymmetry, any leg length discrepancy? What I can see? Okay, so I can see that there is thighs atrophy almost bilateral, and there is a pseudo hypertrophy of both the calf muscles. Okay, I see his ankles. Is there any release scars or anything? And how is his foot?
No.
Is it flat foot or? Okay, fine. And now I see his to his side. I see, do I see any scoliosis or anything? Any kyphosis?
Yes, there is mild scoliosis.
Okay, I see his back. And do I see the scoliosis here also, backside?
Yes.
Okay, fine. Any scars on the back?
No.
Okay, I tell him to walk. So I want to see his gait now. So how is he walking?
Yeah. I'll just share the video.
Okay,
I'm pausing the time.
okay.
So yeah.
Yeah. Okay, fine. Now I tell him that I will put a sheet down. And can you please sit down, cross leg and get up?
Examiner says do that when he's sitting on the chair.
Okay, fine. No worries. So now I tell him that, okay, please come and sit on the couch. So, so then sorry, I tell him to lie down on the couch. Now I'll do the lower limb examination. So, acha, okay. So I have a chair over there. Can I make him sit and tell him to get up?
Yeah.
Hello? Okay.
Yeah.
So I want to see, I want to see how is he getting up. Okay, fine. Okay. Okay, so now I tell him to come and sleep on the couch. So now I see that his legs are exposed. I ask him, is there any scar under his pants?
No.
Okay, I see both the limbs. Is there any asymmetry? Is there any wasting of the muscles?
Whatever you saw in the picture, no,
Okay,
I can share.
okay. No problem. So now I see the tone. So I move his both the thighs, right side and left side. I see the movement of the foot. So is it hypotonia? Or is it normal tonia or hypotonia?
You can see reduced tone.
Okay. Now I see the tone at the both the knees. So and both the ankles.
Okay. Yeah. Reflexes are
Reduced.
diminished. Yeah.
Okay. No, no. The tone. I
Oh,
see the
tone
tone.
is
Then
reduced.
now.
Tone is reduced.
Yeah, okay. So now I see for the power. So I tell him, can you lift your leg up without folding your knees? So I'm saying if he's able to lift his leg, the right and left leg, is he able to do that?
He is finding it difficult, but he's
Oh,
attempting.
okay, fine. And if I apply small pressure, like resistance against it, is he able to do that at the hip joint? I'm checking the power.
No, he's finding it difficult.
Okay, no worries. Can he take his fold his legs, the knees, right and left, one by one?
Yeah, he's attempting.
Okay, now I tell him that don't let me make it straight. So, and you push my hand. So I'm just checking the knee power against resistance. Is he able to do that?
He is finding it difficult.
Okay, no worries. Now I check at the ankle level. So I tell him to press down, and pedal up, and I'm applying a resistance against it. Is he able to do that?
Yeah, he's attempting.
Okay, no worries. So now I tell him that, okay, so now I see for the reflexes. I'm seeing both the knee reflexes, right and left, and I see for the ankle reflexes. How are they?
3 minutes left. 3 minutes left.
Yeah.
Reflexes are reduced, diminished.
Okay, fine. No worries. So I would like to complete my examination by doing the planters, and I would like to complete by doing upper limb neurological examination, and I would do the cranial nerve examination. So today I have seen 8-year-old child. He looks well. He does not look syndromic. He On inspection, I could see that he has pseudohypertrophy of both the calf muscles, and he had a gait which is myopathic gait. When he has this proximal muscle weakness when he was getting up from the chair. On neurological examination, both the sided the tone has reduced. The power is almost 3/5 at the hip joint, at the knee, and at the ankles. And there were reflexes which were reduced reflexes, and I could not test for the planters.
Okay, so based on your findings, what are your differential diagnosis?
So I think that he is a case of lower motor neuron lesion, most likely Duchenne's muscular dystrophy with pseudohypertrophy of both the calf muscles with proximal muscle weakness.
And any differential diagnosis you would like to give?
So my other differentials will be, it can be a Becker's muscular dystrophy, or it can be other congenital muscular dystrophies, or it can be because of any prolonged steroid use, proximal myopathies, or it can be because of systemic causes such as hypothyroidism, causing the proximal muscle weakness.
Okay, so how do you want to manage this child?
So I would like to take the focus history for this child. I would like to complete the examination, and I would like to run few tests. Before that, I would like to involve my consultant. I would send the diagnostic test would be, I would like to send the CPK levels, which I expect them to be high. The diagnostic investigation would be the genetic test. In very few cases, if the diagnosis is in doubt, we do the muscle biopsy. Rest other supportive tests, what I would like to do is the 2D echo for the cardiac involvement, and I would like to do the blood sugar levels for the glucose. And I would like to treat this child. I would involve a multidisciplinary team. This child will need supplementation in the form of calcium and the vitamin D. Steroids can be used for prolongation of the locomotive function, and the definitive treatment would be gene therapy. And this child will need long-term management in the form of a pediatrician, occupational therapist for the attainment of the function, physiotherapist for the muscle health. This child might need orthotics for the support. This child might need cardiologist if there is cardiac involvement, and endocrinologist in case if there is endocrine involvement. This child will need geneticist opinion, and this child will need liaison with the school. And education to the family and to the child, and community pediatrician to join everybody.
Okay, yeah. Your time is up. Yes, that
Okay.
was a very good presentation, Dr. Sarika. Like I thought because you were verbalizing everything, I thought you may not finish on time, but then I mean you seem to have enough time and you were able to complete it properly. Yes, so this was Warning Guide for differential diagnosis. Usually, what we say in clinical station is try to give an umbrella diagnosis, instead of going into specific diagnosis, because obviously you're just examining the patient for only 5 minutes, if at all maximum. When you cut down time for you introducing yourself and then developing rapport, so
Yeah.
it'll only be like 5 minutes that will be there for examination. So obviously, they won't expect you to immediately, make a diagnosis. You don't have the history, you don't have any other information. So always try to give an umbrella diagnosis. So this will be lower motor neuron lesion with waddling gait for differential diagnosis. And then your top differential will be the Duchenne's muscular dystrophy, then Becker's, and then every other proximal myopathy, like you said, hypothyroidism.
Okay.
Other congenital myopathies, but then they are quite unlikely in this child because of other findings that are there.
Okay.
Yeah. Otherwise, your structure of examination, all the general examination things that you try to pick up, and then your structure of examination for motor system for the lower limbs, everything was very good. Just one thing is that you made the child lie down on the couch, and then you wanted the child to come back and sit.
No, I actually, I forgot that you said that there is a chair there. Maybe I'm not supposed to make the child sit down and get up, and I'm supposed to that I click later. So then that's why that confusion happened.
Yeah. So
Oh,
examiner usually want us to make sure that we don't disturb the
yeah.
patient as much as possible, because obviously it's a small child, and they have to make the child sit for exam for so many candidates.
Yes,
So
I will take care of this. Yeah. Okay.
yeah,
So we should
just
not
make
ask
sure that
them.
we should go back and forth. Like she made the child lie down, and then she made the child come back and sit in the chair, and then she again made the child
Oh,
go back and lie down.
okay.
Try not
Yeah,
to go
yeah,
back and
yeah.
forth.
I
The
was
child
asking
is
about
standing.
sitting down and getting up. So is it allowed?
Oh, okay. Yeah, like she did when you'll ask the examiner if she can put the sheet down and make the child sit down and get up to check for Gover sign. If the examiner agrees, then you can do that. Usually, they don't want the patient to sit on the floor and all, even if you use a sheet. So then they can suggest that you can use a chair instead of sheet. I mean, it depends on the patient's mood, depends on the examiner, lots of things.
Okay, ma'am.
So then management part also, it was all very good. Like you talked about the multidisciplinary team, who all will be involved, and then maybe you could also talk about physiotherapy will be graded exercises to maintain mobility of the involved limbs, and then that pharmacological treatment you could have talked about. Steroids will be the mainstay of treatment pretty soon, along with that newer treatments which are all available like ataluren,
Yeah, I was confused.
vamorolone,
Like,
and then gene therapy.
am I supposed to tell that on my own or only if the examiner asks me? Like I said that there is gene therapy which is available, but am I supposed to say Atalorin or
Yeah.
anything?
Yeah, if you have time, you can definitely tell because that is approved treatment, so you can definitely tell.
Okay, okay, fine.
I have just put up some extra points for Duchenne's muscular dystrophy. So there are supposed to be 5 stages, like pre-symptomatic stage, early ambulatory stage, late ambulatory stage, early non-ambulatory stage, and late non-ambulatory stage. The thing about these is that even though the child can walk, the power need not be like what someone has posted in chat, no, Dr. Rokshana, need not be always 4 by 5. Obviously, the child it can maximum be 3 plus, because the child can be from early ambulatory to late ambulatory stage also. I mean, there will be an increased walking difficulty and loss of ability to climb stairs and get up from ground. All those will start worsening. So when the child is in from going from one stage to another, it doesn't necessarily have to be one particular power. So it can even be 3 plus, or it can be 3, even if the child is walking, like what you meant. So early non-ambulatory stages, which are used, like they will be able to walk, then they won't be able to walk long distances. They might have to use a wheelchair for long distances. Non-ambulatory is when they are not able to, even walk even for small ones. And then it'll go into worsening into, involving the upper extremities and truncal muscles, everything.
Now, if
And
this
there is also
child
another
comes
clinical sign.
later,
Sometimes,
sorry,
yes, Dr. Sarika.
I was asking
Yes,
if
yes,
at all
please.
we have this child in this stage where the child is not able to walk and if the child is on wheelchair, So we will not be able to do the gate, and we would not be able to do the Goa sign also, right?
Yeah, we can just politely ask for that. And sometimes because of easy fatigability, they'll be using wheelchair. The child, if in the early non-ambulatory stage, the child will still be able to walk, but then won't be able to walk long distances. But I mean, just when you just look at the child sitting on a wheelchair, you don't know in which stage the child is. So you can just politely ask the mother if the child can stand or if the child can walk. If the mother agrees, then we can still check gait.
Okay.
If the mother says no, he cannot, then it'll be like make the child lie on the couch and just do examination there, skipping the gate.
Okay.
Ma'am, I have got one question.
Yes.
If the child is already, as Dr. Sarika asked, that if the child is already in wheelchair, so how do we reach to a diagnosis in that case? Like in
Yeah.
late
So
non-ambulatory.
the section of examination will be the same. Like you will politely ask the mother if the child will be able to stand. If the mother says yes, then make the child stand and then inspect from front, side, back. So then you would have found a pseudo hypertrophy, calf hypertrophy you would have picked up. And then you can ask the mother if it is okay to make the child walk. If the mother agrees with, that the child can walk, then you'll be able to pick up the waddling gait. If the mother says that no, he cannot walk, or even if the mother says that he cannot stand either, then you can ask to place the child on the couch and proceed with your examination. So then you'll check tone, power, reflexes. Tone, power, reflexes, everything will be diminished. So then you'll know that it's a lower motor neuron lesion. And then you'll give even wider differential diagnosis.
Okay, thank you.
If you're able to pick up the calf hypertrophy when the child is on the wheelchair or when the child is laying down, then you can probably narrow it down.
Thank you, ma'am.
So when they ask how will you manage, what you will say is you want to ask history about how the child was previously. Has the child always never walked, or was the child walking previously and then it deteriorated? All those you can say in your discussion so that it is clearer. The examiner will also know that you thought of all the lower motor neuron lesions, like that are progressive, not just spinal muscular atrophy, and all those severe diseases. Even someone has post-injury spinal muscular atrophy type 3 is quite mild compared to the other types. So, and then there is another clinical sign that some of the examiners might ask, but usually not expected to be done, in exam. Called the Miriam sign, wherein the child slips through the examiner's grasp when lifted under arms. They are trying to lift the child, and then the child is slipping through. The child, the child is not able to maintain tone in the truncal area or in the upper extremity. That the child is not able to stand. This is almost like a newborn examination, no? But yeah, this is called Miriam sign. Usually not expected to be done in exam, but then they can ask in discussion part. Yes, any doubts? I hope we were clear with the approach of the scenarios that were discussed today. Okay. Uh, so those who weren't there at the start of the uh, class, so we are planning to start our next course for Diet 1 for January, February 2026 exams. Whoever wishes to join can, contact the given number. And we also have our website, targetmrcpch.com, where from you can download the app also. It's available for both Android and Apple iOS, and we have various courses. If at all you're downloading from an Apple device, then this code has to be typed in. That is just an extra. You can probably take a screenshot of this and enter the code when you're reading. So, depending on which stage of learning you are, we have all three. If you are at the beginner stage, then this has resources for all the stations, including video station. If you're somewhere in between, have 2 to 3 months time, like from now, if you're starting now or something, then intensive revision has such material, and then crash course is for 2 close to exams. So these are the WhatsApp groups where you can join. You can scan the QR code and join. Share the QR code with your friends also so that they can join the group. So yeah, thank you everyone. Thank you.